Good morning. In this video, I will talk to you about the various types of infiltrations that are commonly done in medical offices. I want to clarify that this video, like all the others on my website and YouTube channel, is in no way intended to replace the advice your doctor gives you. Infiltrations are commonly done to reduce pain and to counteract inflammation and to try to lubricate and nourish the joint, even if, unfortunately, it is not possible to reconstruct the damaged cartilage. Infiltrations consist of one or more punctures, using needles that vary in length, depending on the area of the body to be infiltrated. This is obviously an invasive procedure, although it's almost always minimally painful. The technique I use is the so-called no-touch technique. This is the safest way to avoid infection. The needle entry point must be identified before disinfecting, not the other way around. Once you're certain of the needle entry point, you disinfect it repeatedly before inserting a thin needle. Very often, preoperative anesthesia isn't even necessary. Infiltrations are essentially divided into those performed inside or outside the joint, depending on the area where the drug is injected. The most commonly performed joint infiltrations are those at the knee, shoulder, hip, and ankle. For injections into the joints of the foot, ankle, or hip, it is always advisable to use an X-ray or ultrasound to ensure the needle is in the right place, thus avoiding injecting the drug into an area other than the intended one. In these cases, identifying the joint space is not always easy. In the first example I present to you, I use the no-touch technique to infiltrate the left ankle of a patient who continues to have pain and a sense of instability after an ankle fracture operated on by inserting a plate and screws that, to be precise, I did not make. The first phase, as I have already said, is to identify where to enter with the needle by simply using the low-intensity X-ray device. I check and mark the entry point. After repeatedly disinfecting the skin, without even administering local anesthesia, I insert the needle into the joint. The first part of the injection involves injecting a small amount of contrast medium, which provides definitive confirmation that the procedure is in the right place. In fact, the contrast medium distributes itself completely differently within the joint than if it were outside the joint. Once we're certain it's inside the joint, the actual injection is performed, which in this case consists of a small dose of cortisone and local anesthetic. It must be performed under ultrasound control, as I will demonstrate in this video that was kindly provided to me by a friend and colleague who is a radiologist. In this case, the technique is slightly different, but obviously requires thorough disinfection. After preparing the sterile field, using the ultrasound probe held in the radiologist's left hand, the needle is checked to ensure it is in the desired position by looking at the monitor located in the upper right corner. Only then is the drug injected. As for extra-articular infiltrations, i.e. outside the joint, the most commonly performed ones are at the elbow, the knee for bursitis, the shoulder at the level of the rotator cuff, the heel for plantar fasciitis, and near the toes for Morton's neuroma. You can find the informative video on my YouTube channel or on my website. Infiltrations vary not only by the anatomical area, as I explained earlier, but also by the substance injected. The most commonly used drug is cortisone, which is often combined with a local anesthetic for a rapid effect. Hyaluronic acid is another widely used drug, especially for joints, while the use of platelet concentrate, which I'll discuss later, is much more recent. There are also other, less common types of infiltration, which involve the injection of ozone, in the form of a gas or a type of alcohol to denature the tissue used, for example, for Morton's neuroma. Alcohol injections require more intense anesthesia because alcohol injections can otherwise be very painful. Another type of infiltration is radiofrequency. In this case, no drug is injected, but a special needle is used to emit energy deep into the tissue, permanently numbing the nerves immediately surrounding the needle. As I mentioned, cortisone is the most commonly used medication for injections. It's not the purpose of this video to discuss the negative effects of cortisone, but I want to highlight a possible side effect of this medication, especially if multiple injections are given in the same area. I'm referring to the possible weakening of tendons and ligaments, which is why cortisone should never be injected near the Achilles tendon, as it could cause spontaneous rupture of this anatomical structure. Furthermore, cortisone can cause local cartilage damage when used excessively in a joint. For this reason, it's generally recommended not to perform more than 3 injections in the same joint over the course of a year. Although uncommon, a cortisone injection can lead to an increase in blood sugar levels, so diabetic patients must be extremely cautious and monitor their blood sugar levels when they return home. Although rare, injected cortisone can lead to an increase in blood pressure, especially in patients who already have hypertension. Furthermore, cortisone can also cause a reduction in local immune defenses, thus increasing the risk of infection. Immunosuppressed patients should try to avoid it. A first alternative to the use of cortisone is hyaluronic acid, especially for lubricating the joints. Hyaluronic acid does not cause the typical side effects of cortisone and can therefore be safely repeated several times a year. It is a preparation purchased in pharmacies and unfortunately is not recognized by insurance companies and therefore must be purchased directly by the patient. The same applies to the second alternative to cortisone, which is the one known as platelet concentrate, but which in English literature is generally indicated with the acronym PRP. PRP is obtained by centrifugation of a normal blood sample collected from the patient. Typically, 15 milliliters of blood is drawn into a test tube, which is then inserted into a centrifuge rotating at several thousand revolutions per minute. The centrifugation process separates a liquid component, rich in platelets, which in turn are rich in growth factors, thus concentrating them in a small volume of liquid. It is believed, but there is not yet satisfactory scientific evidence, that this compound can stimulate tissue repair. This technology has many applications, although there is not yet adequate scientific evidence, including osteoarthritis of the knee, hip, ankle, and shoulder, as well as osteochondral lesions, tendon disorders of the shoulder or Achilles tendon, epicondylitis of the elbow, and even plantar fasciitis of the foot. Regardless of what was injected, it's still advisable to avoid swimming or saunas for the first 24 hours after the injection. You can walk or drive after the injection, although it's important to keep in mind that pain may sometimes increase for the first 48 hours, especially if the injection was done in the foot or ankle. In this case, it is obviously a good idea to apply ice locally and also take a painkiller. Although the effect of the infiltration generally manifests itself quite quickly, there are cases where it requires more time, and I am referring above all to cortisone, which can sometimes take up to 5 or 7 days to take effect.